So today, again, our presentation is with Dr. Jack Barkin. It's on HIFU, 18 years young, a most effective, minimally invasive outpatient treatment for localized prostate cancer. Dr. Jack Barkin is Medical Director of Can-Am HIFU Incorporated, Medical Director of Can-Am HIFU National, Clinical Professor of the Department of Surgery at the University of Toronto, Associate Professor at the Division of Urology at the University of Toronto, Executive Editor-in-Chief of the Canadian Journal of Urology, and the past Chief of Staff, Chief of Surgery, and Head of Surgical Oncology, Chief of Urology at Humber River Hospital in Toronto. So without further ado, I will stop sharing my screen and let Dr. Jack Barkin continue.
Perfect. Well, thank you very much, Meyer, for this introduction, and
Of course.
welcome to everyone. It's nice to see a number of faces from across Canada, I assume, and hopefully I will be able to give you some information this afternoon, and I'm happy to answer your questions as always. So, high-intensity focused ultrasound. Where do we start? So, my agenda for this afternoon, in the next 3 or 4 hours or so, HIFU is an option versus surgery and radiation, because that's obviously what we're talking about. We talk about whole gland treatment, bit of an idea about diagnosis and management of prostate cancer in itself, the appropriate patient, risks and benefits, success rates, how we follow these patients, and then what happens if there's a recurrence after treatment of prostate cancer, and obviously the new developments. And then ultimately as well, the question, because HIFU today all across Canada is a private procedure. It's approved, but not insured. So some statistics, which I'm sure, unfortunately, you gentlemen and ladies know even as well as I do, if not better. And these are 2023 statistics, 25,000, almost 26,000 men will be diagnosed in Canada alone. So 21% of all new cancers diagnosed in Canada will be prostate cancer. Death from prostate cancer, again, euphemistically, some of our politicians say men die with prostate cancer, not of prostate cancer. Well, it's very significant. Death from prostate cancer, still 13 men per day in Canada alone, 10% of cancer deaths from that. Number diagnosed weekly, 497. So across Canada, over 70 patients per day are being diagnosed. Overall, in general, we say 1 in 8 men will develop prostate cancer, usually after the age of 70. 1 in 30 will die from it. So in North America now, the #1 diagnosed cancer in men in North America, and depending on which year, what you're looking at, it's either the second or third commonest killing cancer in man. Some American statistics, so here 2014, number of cancer survivors, prostate cancer survivors, almost 3 million, 43%. And in 2024, almost 4,200,000, 45%. So huge number of increase in about 10 years' time. Obviously, over 1.2 million additional men diagnosed with prostate cancer, but are still living with prostate cancer, not dying from it because of our new treatment approaches. So in the American scenario, we're looking at those patients that would qualify for treatment with a relatively non-invasive procedure. So six cases in 10 are diagnosed in men under the age of 65, rare before the age of 40. The average age in the United States is about 66, so still very young men, anticipating at least another, hopefully 20 to 30 years of good quality life, ideally. So who could really be attracted to or be appropriate for prostate cancer treatment with HIFU? Any man currently diagnosed with prostate cancer, depending on the criteria. Active surveillance patients that are escaping from active surveillance, who are getting very concerned about the constant DREs and PSAs and worried about when the shoe will drop. Although, as my colleague Lori Klotz, colleague, partner, friend, and classmate has espoused over the last number of years, about 30 to 35% of men diagnosed with Gleason 3+4 prostate cancer have a risk of progressing over the next 5 to 10 years. So, that's a very select group, and that's why we use it. And in the right patient, they can go for many, many years without any problems. And then men who have had already radiation treatment and have had radiation failures. So these are the kind of numbers we're looking at in the United States on a potential basis for HIFU. And just as an aside, so how do we treat men diagnosed with localized prostate cancer, meaning you've had the workup, diagnosed with prostate cancer, regardless of the Gleason score at this point in time, and the decision is how do we manage it, assuming that there is no evidence of spread beyond the prostate to the bones or small tissue or soft tissue, lymph nodes, whatever it happens to be. So radical prostatectomy, again, now we're treating the whole prostate, either open or robotic, which has gained acceptance over the last probably 15 years in Canada. I've been doing robotic surgery since 2011. External beam radiation, and there's different qualities and of external beam, the intermodulated radiation therapy, the SBRT, the external, and then we have brachytherapy, the radioactive seed implantation, and sometimes a combination of both, depending on which center you are engaged with and what they recommend. And there's a concept of focal therapy, or then proton beam, which is another escalation of radiation, again, not available in many other places. Then we come down to focal therapy, which we'll just address at the moment very quickly. HIFU, high-intensity focused ultrasound, cryotherapy, and there's only, I think, one center in Canada that's actually doing it, and usually for total, not for focal at all. CyberKnife, something relatively new, very few centers in Canada, and Tulsa, at the moment, only one center in Canada, which is also using focused ultrasound, but transurethral ultrasound rather than transrectal ultrasound, which is HIFU. And again, we'll come back to all of that. So what do we know? In treatment of the total prostate by doing a radical prostatectomy, whether it be robotic or open radical prostatectomy, in controlled T1, T2 disease, meaning totally confined to the prostate, obviously, reported recurrence rates, and that's either PSA failure, what we call biochemical failure or biochemical disease-free rates, local recurrence within the prostatic bed, or systemic. So this is the kind of statistics we're looking at. 20 to 30% at 5 years will have some degree of failure. And again, this is not stratified based on the initial Gleason score. This is overall. And at 10 years, it increases to almost 50% again, overall. Looking at radiation therapy, again, looking at the whole numbers and different types of radiation that have been delivered to the patient or offered to the individual patient, external, brachy, depending on the situation. So it's about 34%, same, totally confined to the prostate, and at 10 years, 46, 66%. So almost same. Again, variation in the sense that because there's so many different trials and a number of different reports as how we look to, that's why the numbers vary, but it's very similar. The other concern, and I'm sure any of you that have had radiation or considering radiation, the radiation oncologist that you've spoken to, I would hope, has been honest in his, obviously, transparency in some of these concepts, that even though it's pelvic radiation, we're seeing an increase in the number of patients subsequent to pelvic radiation or even chest radiation for lung cancer treatment, that increased risk of developing bladder cancer, and not insignificant bladder cancer, as we call the non-muscle invasive bladder cancer, but bladder cancer requiring cystectomy, actually a threefold increase in those men who have had radiation treatment. And even an increase in lung cancer after they've had pelvic cancer. So the corollary is the same too. As I said, men who've had radiation for lung cancer also have an increased rate of bladder cancer. And those that have had treatment for prostate cancer, pelvic radiation, have an increased risk of lung cancer. And then this final one, about a 1.7-fold higher rate of developing rectal cancer as well. So radiation, without question, for the last 60 years or so, has had tremendous impact on all kinds of different cancers. We use it for primarily as well as for salvage, but there are potential long-term risks as well. Again, overall, looking at some of our treatments for total gland treatment. So radical prostatectomy, cryosurgery for total gland, or total ablation as we call it, brachytherapy, external beam radiation, three-dimensional, the standard external beam, which is SBRT, and then finally HIFU. These are the kind of statistics, low risk, meaning Gleason 3+4 or less. And then we get to the moderate to intermediate, 4+3 or higher Gleason score out of 10. And these are the kind of numbers you're looking at as far as biochemical disease-free, meaning no evidence of PSA, which, as we know, is our surrogate marker for control of the cancer. And that's how we monitor our treatment response after treatment. So what do we look to as far as our optimal outcomes? And that's the most important thing too. You can offer a treatment, but as we've seen in medicine, and every day I speak to a patient, we have to have this discussion, an honest discussion about the risk-benefit ratio, regardless of the condition that I'm trying to treat, whether it be BPH, benign prostatic hyperplasia, prostate cancer, bladder cancer, kidney cancer, penile cancer, lesions, whatever it happens to be. And we talk about the benefits of treatment naturally, but then the risks and the risk of how it can affect them and their quality of life. So the three things we look at for the optimal outcomes, we say the trifecta in prostate cancer management, is the patient has a PSA control. That's what we want to do, is to treat the cancer. That's the primary thing. The second, though, is that they should be dry without the use of pads. So incontinence is a risk regardless of the treatment that we're offering. And the other consideration from the quality of life, obviously, is potency, the ability to obtain an erection for satisfactory intercourse. And way back when, 25 years now, virtually to the day, I actually launched Viagra, Levitra, and Cialis in Canada. I did all the media work for that 25 years ago, and I was in the newspaper and all across Canada and all kinds of other exciting things. And in this survey, which was done at MSK, Memorial Sloan Kettering, so one of the top cancer treatment centers in the world, what they use for their criteria for success is a PSA at 0.2, which, as we know today, is not exactly what we want to see. We want it less than 0.002 or less than 0.008 as being total control, dry without pads. I mean, they talk about their potency. It was either with or without the PDE5s of Viagra, Levitra, Cialis. So here's a study by one of the top centers in the world. Average age 58, so young men, nerve-sparing radical prostatectomy, bilateral 94% based on the surgeon's report, obviously. And what they saw of the total trifecta, continence, PSA control, and potent, even with the PDE5s, only 30% at 1 year. It actually increased over time, and this is what we've seen after surgeries, that the erections can come back. But even at 4 years, which is I guess the optimum time that they assessed, 53% at 4 years with the trifecta itself. So what do we look to? The perfect prostate cancer treatment, if we say it, is that the best treatment is one that balances quality of life and PSA control. So this reminds me of the story about the two 5-year-old boys that were talking to each other because the teacher had mentioned the word penis in school, and neither of them knew what it was. So Johnny looked at Billy, he said, "You know what it was?" So he said, "No, I don't know what that word means." He said, "You know what it is?" "I don't know what that means either." So well, we should find out. So that night, Johnny went home to his dad, spoke to his father. He said, "Dad, the teacher mentioned this word penis. I didn't know what it was. Billy didn't know what it was. Can you tell me?" So the father takes the son and says, "Come here, son, I will show you." The father takes the son into the bathroom. Father pulls down his pants and he points down and he says, "You see this thing, son?" He says, "Yes, son." He says, "Well, son, this is a penis." So it's really, Dad, this is a penis. And son, not only is this a penis, but this is a perfect penis. I said, "Gee, that's fantastic. My dad's got a perfect penis." Next day, Billy goes running back to school, finds his friend Johnny. He said, "Johnny, did you find out what it was?" He said, "No, I didn't. Did you?" He said, "Yeah, I did, as a matter of fact. Come here, I'll show you." So the two 5-year-olds go into the bathroom. Billy pulls down his pants. He points out, "You see this thing, Johnny?" He says, "Yeah." "Johnny, this is a penis." He says, "Really? That's a penis?" I said, "Yeah, this is a penis." He says, "And not only is this a penis, but if it was 2 inches shorter, it would be a perfect penis." So I can't hear you laughing, but hopefully you are. So this is the key here. We want to create the perfect prostate procedure. So what are we looking for? Again, the trifecta in prostate cancer treatment, PSA control. Again, the patient doesn't die from prostate cancer. And this is what, again, going back to the political euphemism, men die with it, not of it. We've already demonstrated that lots of men still die from prostate cancer. And that's what we want to stop. So they may get recurrence, but as long as we can control, they don't die from it. That's the ideal. Continent and good preservation of erectile function. So that brings me to HIFU. Why? Why did I become involved with HIFU, high intensity focused ultrasound, way back now, almost 20 years ago? The key was that regardless of the treatment we were offering, and I'm a surgeon, so I did a lot of surgery, saw a lot of patients for radiation, we were not curing all men. And also we were diagnosing it even at a younger age, and we were causing a lot of problems with our patients that we were trying to treat, attempting to treat, in treating them with external beam radiation, brachytherapy, radical surgery, because the quality of life was not great. So in 2000, I started doing it in Mexico. Very unusual to go to Mexico to learn how to do a treatment, but it was not USA approved, and it was not Canadian approved, but it was available in Mexico. So I went down to Mexico to learn how to do it from actually an American surgeon who was working in Mexico with HIFU. And in January 2006, it became approved in Canada, not insured, but approved. And I opened the first unit, and literally it's been 18 years and 2 weeks, almost to the day, that I did the first HIFU treatment in Canada, in Toronto, which is part of Canada, as we all know. So I have 5 partners. Again, some of the names you should recognize: Drs. Neil Fleshner, past chairman of urology at UHN, University Health Network in Toronto, chairman of urology at University of Toronto; Laurie Klotz at Sunnybrook Hospital in Toronto; Dr. Tony Finelli, who's presently the chairman of urology at U of T, as well as the chief of urology at UHN in Toronto; Nathan Perlis and Dean Elton, 2 other significant urologists at UHN in Toronto. And across Canada, this is Can-Am HIFU National. I have Dr. Marty Gleave and Alan So out of Vancouver, Dr. Dale Drachtenberg in Winnipeg, Manitoba, Andrew Pfeiffer in Mississauga, Ontario, and Bobby Shagan in Hamilton, Ontario. To this day, 18 years of experience, over 3,000 patients that we have treated as a group. And we've evolved from total to focal HIFU with cognitive MRI, as well as treating radiation failure. So what is HIFU? Non-invasive acoustic, meaning sound wave ablation, that uses intersecting precision-focused ultrasound waves to cook the prostate to 100 degrees Celsius, or at least 65 degrees Celsius, which has been determined to kill tissue. It destroys the targeted tissue at a focal point. So just the area that we are targeting is what's destroyed, and ideally the surrounding tissue is not destroyed. And the point is that we're developing or delivering a significant amount of energy, heat energy, with acoustic waves, the same ultrasound waves that we use to do your ultrasounds in various areas of the body, but at a different frequency that causes heat to be delivered. But we don't want the heat to go anywhere except to where we are directing it to prevent other side effects. So high intensity ultrasonic bursts of energy, short bursts, 3-second burst of energy. And we have determined what energy level should be delivered depending on how far one is from the focal point that you are starting or initiating the energy from, and we'll come back to that. So we can change the energy intensity levels. And the other thing that we have to be cognizant of is that the energy does not necessarily transmit completely, depending on what's happening within the tissue itself. There's some absorption, some cooling things that take place. So is there a way that we can actually monitor on a literally second-by-second basis to see if we are achieving the energy or the temperatures at the focal point, the point where we're delivering energy, that we believe we are, or we hope to achieve in treating with HIFU? So tissue in the region of the focal zone, where the sound waves converge at a higher energy than where the sound waves start, because there's a convergence. It's a combination or focusing of these energy from a wider transducer. The source is the transducer, which is low density energy, as it's called, and then the target is what absorbs rapid heating and absorption of the heat so that the tissue dies. It's ablated. And it's the old, as we said, the magnifying glass technique. When we were kids, we would have a magnifying glass, and the magnifying glass would be 14 inches from the leaf, and we focus the sun waves, or the sun's shine waves, to that pinpoint to burn the hole in that leaf 10 inches away. But if you put your hand in between, nothing would happen to your hand because the focal point is beyond that. And that's exactly what we are doing here. But the key is to develop what's called a precise and repeatable lesion, only specific configuration, specific diameter or length, width, and height. And it's repeatable. And this is what shows us what's happened in temperature over time. So for the 3-second burst of energy at the focal point, we're reaching temperatures anywhere from 65 to 100 degrees Celsius. But as you get towards the peripheral zone, so further away from the source of the energy, which is down here, just outside of the rectum, so you can see in the peripheral zone of the prostate, further away from the point that we are treating, the temperature is way down at about 36, and then even lower than that right at the rectal wall. And we also provide rectal cooling by cold water that's being transmitted through the transducer continuously as you're offering treatment. So there's additional rectal cooling to prevent any absorption of heat at the rectum. So the tissue effect is a function of the frequency of the wavelength of the energy, the ultrasound beam. And that's why our frequency is different than the frequency that we use to visualize the prostate, although within our transducer, we have both. We have the treatment crystal as well as the imaging crystal. And again, we'll see that. And then the energy intensity, which is usually set at 4 megahertz on our probes, and actually our probes are 6 megahertz to give us a better view of the prostate as we are treating it. Things that can interfere with the prostate or the transmission of the energy are calcifications if they are significant. So the sound wave will hit the calcification and be reflected back. It will bounce back rather than going through the tissue to reach the focal point that we are hoping to define in the way that we have set up the prostate cancer treatment. So wide degree of calcification within a prostate can be a contraindication to HIFU therapy because the beam will not reach the point that we want it to reach, and it could get what's called near field heating, that the area before the focal point gets heated where we don't want it to be heated. The other things that can change the absorption of the energy is if there's significant blood flow in an area, so that the blood flow, the blood vessels act as a heat sink. So it's drawing the temperature or the heat away from the area of treatment. Hormone therapy changes the characteristics of the tissue itself, so it may not be absorbed in the same manner, and previous treatment with radiation, et cetera, can also affect it. So things we have to consider. 1972 was the first concept of high-intensity focused ultrasound, and this was done in Indianapolis, as we say, and this was for brain treatment of brain tumors, not prostate tumors. And then we've moved ahead, and the initial thought with respect to using focused ultrasound for the prostate was to treat benign disease. And it took a very long time to treat a benign enlargement of the prostate, but we're seeing using it for treating cancer, it was much more effective and much more beneficial. So there are 2 machines available. And in Canada, at the moment, there are actually only 2 machines. One is in Montreal, which is this Ablather machine, which is a French machine, it's called. And as you can see here, there's a big table, and the patient lies on the table on his side, and the probe goes up the backside, and there's some special cooling solution that's being delivered. And then the operator, the surgeon, is standing at the console looking at this particular thing and operating the machine. The machine that I've been using from day one, and I had the choice of both, and I chose this one, is actually an American machine called the SonaCare machine, or SonaBlade machine, that has been, obviously, is produced in the United States, even though until 2018, it wasn't actually approved in the United States. Actually, I'm sorry, 2018. So about 12 years or 16 years after we were approved in Canada. So a much more mobile machine, much smaller. This is, the screen is obviously combined with the actual module that provides the treatment. And this is what's called our chiller that delivers chilled water through the probe itself on a continuous basis to help cool the rectum. And it has an arm that it stabilizes it within the thing. So the old model for diagnosing prostate cancer, a man had a PSA, and regardless of what the family practice people have been saying for the last number of years, unfortunately, men should still have their PSA done as a screening test, even without symptoms, starting at the age of 50. Abnormal PSA that led to a biopsy, which we called the random ultrasound-guided biopsy, and it was systematic and based on a specific pattern. We did usually 6 per side, base, mid-zone, and apex, medial and lateral, left side and right side. Once the diagnosis was made, no further assessments were made except for doing a systemic CAT scan and bone scan to make sure there's no obvious spread. Then the man had radiation or surgery. That was the issue. So then, could we add HIFU to the treatment? So the answer was yes. And from 2006, been doing HIFU for total gland ablation, treating the whole prostate. And how did we treat? Using this transducer up the backside. And this is the first difference between the SonaBlade, the machine that I'm using, that each time one of these little artifacts is created for, basically it's 3 seconds on, another 3-second burst of energy, then a 3-second cooling cycle. So 9 seconds in total per segment. I treat an area 3 millimeters by 3 by 12 millimeters high, which is important. Whereas on the Ablatherm, the French machine, they're treating 3 by 3 by 19 to 24 millimeters high. So very significant difference. And why is that important? Because when you come to the edge of the prostate and you want to get at least 1/3 of the bar within the treatment zone, if your bar is 24 millimeters high, you have to be pretty far back from the edge in order to keep 1/3 of that bar within the zone, because otherwise the majority of it is going to be outside the zone. So when I treat with a smaller lesion, I can get much closer to the edge of the prostate. And that's here is what we call the anterior, or the top of the prostate, the middle zone, because then when I treat the posterior zone, that overlying the rectum, I actually internally rotate the probe itself. I don't have to change probes. This crystal, this black thing, turns around on itself from a command from the computer, such that on the other side, the treatment that I create is 3 by 3 by 10 millimeters high. So it's even shorter, more precise for that area overlying the rectum. We have much less buffering area. We want to make sure we're only delivering the energy to that spot within the prostate. So again, some of the differences between the SonaBlade, my machine, versus the French machine, because we have my focal point or focal length of the big probe is 4 centimeters. Theirs is only 24 millimeters, or 2.5 centimeters. So we can treat much bigger prostates. I also, on the image quality and on my screen, there are 4 images looking at the prostate face on, both before treatment and during treatment, looking at the prostate from the side of the sagittal image before treatment and during treatment. Plus, I can get a 3-dimensional view of the prostate during treatment or as I'm doing my planning. So they can't do 3D at all, where I can. The other thing I have built into my machine is Doppler studies. So I can outline and map the nerves on the posterior layer, so I can do a nerve sparing HIFU treatment, stay away from the nerves. They don't have built-in Doppler as well. Second thing is, even though my focal length of the probe is longer than theirs, significantly longer, the diameter of the probe is actually smaller. And you have to be able to get 2 fingers into the rectum with some gentle dilation. And I've had patients that initially had gone for ablatherm treatment where they couldn't get the probe up the backside, that I was able to do them with our probe, which is much smaller. The other thing, on the ablatherm, they have 3 temperature settings. A new prostate cancer treatment, a prostate that previously been treated with HIFU, or one previously treated with radiation. 3 fixed cancer or temperature modulations, if you will, or temperature setting. Whereas in mine, it's totally without range. On the 4-centimeter probe, I can go anywhere from 24 watts of energy up to 42, whereas on the 3-centimeter probe, once I've switched over to 3-centimeter, it only goes a maximum of 24 watts from 0 to 24, again, to protect the prostate in that area overlying the rectum. So even if I wanted to deliver higher energy, I could not do it. 12-millimeter lesions, we've already talked about, compared to 19 to 24, and lots of other safety features in the monitoring showing me if my energy is being delivered to the spot that I want it to be delivered to, and if I'm getting the right temperature. So who should we treat for total prostate gland treatment using HIFU? T1, T3, so lesions ideally confined to the prostate or just at the margins of the prostate. Localized or recurrent after radiation treatment. Ideally, the prostate volume should be less than 40 cc's. That's the ideal thing. And again, without a lot of calcification, as we've talked about here, minimal calcifications. The other benefit is that there's no cutting and there's no bleeding. So even patients on anticoagulation can be treated as long as you can get the probe up the backside. The only consideration for anticoagulation is because we do these procedures under spinal anesthetic. One can do it under general, but I do it in an outpatient setting, so it's done under spinal anesthetic. So it's more for the anesthetists who's putting in the spinal that they want them off anticoagulants for a few days beforehand, so there's no bleeding when they do that spinal tap to deliver that. After the HIFU treatment, usually if I do total HIFU treatment or total ablation, they will have a suprapubic catheter that stays in for a determination. We determine that depending on the size of the prostate. And why do we put in a catheter at all, whether it be a Foley or a suprapubic? Because the prostate will swell before it shrinks with respect to treatment. And that swelling can put you into retention. So we're proactive in the sense that we don't want you to be in retention, especially if you're traveling from across Canada. So we leave the catheter in for a period of time, and we determine when's the optimum time to remove either the suprapubic and do what's called a trial of avoiding, or remove the Foley catheter and do the same trial of avoiding. We provide anti-alpha blocker therapy, again, to encourage the prostate to come back to normal functioning as quickly as possible, normal voiding function. As you know, the alpha blockers open up the prostate, try not to instrument early, treat LUT symptoms, frequency, urgency that may be irritative voiding symptoms with anticholinergics if necessary. And overall, early on, this is what we're looking at. There's a potential for developing a scar within the prostate or at the bladder neck because of the treatment, the heat, sometimes, much less now, and the follow-up naturally, as with any prostate cancer treatment, every 3 months for the first couple of years. What did we look at on earlier data on treating total prostates? And Uchida is a guy from Japan who was actually the first one who offered HIFU treatment. On the earlier machines, we call the SonaBlade 200 machine up to the SonaBlade 500 machine. So it's a mixed response, but at 1 year, 91%, negative biopsy rate, biochemical disease-free rate at 6 years, 97%, and a PSA nadir staying down of, as we said, as undetectable in those days early on at 84% at 3 months. So very significant. Also mimicked by or mirrored by some other investigators like Emberton out of the UK, who's done a lot of work in this area as well. And then looking at his long-term data now, up to 10 years, and this was a combination of the earlier generation machines, SonaBlade 200, SonaBlade 500, and then the version 4, and then the latest one, which is the one that I use, TCM, stands for tissue change monitoring. So you can see literally second by second, if you achieve the color change, that represents the heat absorption at this focal point of the delivery of your system. So you can feedback and you can see if you've reached that or achieved that goal. And if you haven't, you can go back and retreat that area as many times as you want while you're still there to get to make sure you've treated that area. And so what we've looked at in this particular thing, and again, the best is to look at the latest version of the machine with the longest cohort. Those that have had biopsies, 83% of the patients, so 94% of the patients were biopsy negative at the end of the treatment cycle using the latest machine. Salvage treatment numbers that had to have a second HIFU treatment, which is again the benefit of HIFU. You can treat a second time if you wanted to, biopsy proven area, and just treat that area where there is recurrence. So about almost 10% required at that time. So overall, looking at D'Amico's classification for biochemical disease-free rate based on the device, we see here at 5 years, 82%, 10 years still not out there, and biochemical disease-free rate, again, stratifying by low risk, high risk, or intermediate risk and high risk. So very, very significant. Looking at the low risk patients, the 3+4, 95%, fantastic. And going out to the high risk patients, 5 year, 72%. So comparable to radiation and radical surgery. We talked about the complications, obviously. Those with bladder neck contractures or stricture, minimal procedure that we had to do. This again, earlier data, way back from 2018 and earlier. And the stricture rate, or fistula rate, biggest concern that the energy goes to the wrong location. And in our 3,000 patients, we have had exactly 2 fistulas in 3,000 patients. So, and in both those patients, one was a radiation failure. One was a patient who had a history of Crohn's colitis and did not report to the nurse, the doctor, or the anesthetist at the day of the procedure that for the prior 2 months prior to his HIFU treatment, he had had anywhere from 18 to 24 bowel movements per day. So that's part of our questionnaire. He lied, didn't want to be excluded from HIFU. And unfortunately, he didn't tell us that. He had a great HIFU treatment, developed a fistula. Luckily, he only required a catheter for 6 weeks. It healed. And 12 years later now, actually 14 years later, he is still biochemically disease-free. So he's done exceptionally well. So longest retrospective study showing very significant biochemical disease-free rates and cure using the SonaBlade 500 with tissue change monitoring. And this is what the screen looks like. This is, I sent to you. So this is, as we say, the front view. This is showing the treatment. That yellow spot shows exactly where I am treating. So this is at the top of the prostate. You can see this is the whole prostate here. Base of the prostate, the probe is here in the rectum, shooting the energy to 4 centimeters away. And that little white spot there is what we call calcification or popcorning, showing that I ablated the tissue and it's exploded. It's absorbed the energy, and the fluid or the moisture within the treatment zone has caused steam to create this popcorn effect where it's blown it up. So I can see this. I can see that before treatment, there was no white spot there, but with the treatment, the white spot is there. And as I say, and this is telling me how long the treatment for this particular cycle will take to treat that whole area of the anterior zone of the prostate. Again, measuring the temperature of the probe in the rectum, which is the rectal temperature, which is very low, and showing me the temperature that I'm treating with, 39 watts, etc. So all these things I'm monitoring. Some other results, again, coming out of Mark Emberton in the UK, where actually HIFU is remunerated, so it's part of the national healthcare system, and they've shown also very significant cure rates, mean PSA nadir at 0.15 at 1 month, and these are based on high-intensity focused ultrasound, 34 patients, PSA received. Looking at tissue change monitoring, the feedback. Earlier on, we were doing Gleason 6, and some men are still doing Gleason 6, which, as we know, our qualification or criteria for what we call active surveillance are 3 or fewer cores less Gleason 6, less than 50% of any one core, and PSA less than 10. So in our individuals where we had 4 or greater cores positive, this was not truly a candidate for active surveillance, and they wanted treatment. So early on, we treated a number of patients with only Gleason 6 that we could define based on the biopsy. And these are the kind of numbers we're still looking at. And some of these patients, obviously 138 months, we're talking over 10-year follow-up, where still a significant 43 patients of the original 65 still have PSA at less than, 0 to at 0.18 on average. So still cured at that level. And this is actually what it looks like. So we create a cavity because if you're treating the whole gland, there's like nothing left. It retracts to the capsule as if we had done a TURP or anything else. MRI, same thing, showing this now total defect of where the prostate was. And then looking at the concept that we call urethral sparing, because that was an issue. We had some of these bladder neck contractures or urethral strictures. So if you look at treating with a catheter in place so you stay away from the catheter, and it's still good treatment treating all the prostates you want to treat, that we saw that there was a tremendous ability to maintain the urethra without getting strictures, and our stricture rate reduced to 0.3% in our last 1,000 patients. So the other consideration, prostate cancer, that had been treated with radiation, and could we now offer a treatment to them using HIFU as a non-invasive way of salvaging radiation failure patients. So again, some Canadian investigators as well as American, and at that time, this was the only HIFU that was offered in the United States, only for this clinical trial, only from some significant institutions for prostate cancer radiation failures. So the study, 100 men were treated, biopsy proven, and they had completed their external beam radiation treatment, etc. And this is what we saw in the follow-up, that after salvage HIFU, that we maintain a prostate cancer cure, because when you do radiation treatment and the accepted monitoring for failure of HIFU or radiations, what's called the Phoenix scoring system, which is the PSA nadir, the lowest level of the PSA, plus 1.5 nanogram per milliliter, as determining that you have now failed in your treatment. So the concept of whole gland treatment, when you've proven is very effective and obviously got similar results to radiation treatment or even radical surgery with much less morbidity, then can we do even better? Because we were still causing some treatments, took a long time to treat the whole glands, anywhere from 3 to 4 hours, and the recovery from the whole gland treatment took a lot longer as well, and higher incidence of erectile dysfunction, even though considerably lower than radiation and or surgery, at about 8 to 14% or 15%, depending on the individual. Incontinence with stress, lifting, straining, etc., 1 to 3%. So could we do our HIFU lumpectomy? Similar concept to women today with breast cancer. They take out the breast lump, cancer lump, leaving a margin of safety around it, and the survival recurrence rates are as good as doing total mastectomy. So this changed our paradigm, because again, PSA was the entry criteria, that the men now came for a prostate biopsy. But today in Canada, prior to doing the prostate biopsy or the ultrasound-guided biopsy, or even if they've done the ultrasound-guided biopsy, systematic, when we do that, those of you that have had it, you'll know that we actually monitor and only biopsy the peripheral zone of the prostate, not the anterior zone, not the transitional zone, and no other areas. So the 12 cores are not representative of what's going on in the rest of the prostate. So in those men that have either had an ultrasound biopsy that showed prostate cancer but are now considering focal treatment, I would not offer treatment to them with HIFU unless they've had a follow-up MRI that shows me or proves to the best of our ability in today's standards that there's no areas in spots that have not been assessed by their previous ultrasound biopsies, or no areas of suspicion that would require what's now called a targeted MRI fusion biopsy. Looking at the MRI, combining that with the ultrasound, then going after that spot that is based on suspicion on the MRI, as this spot here is showing us that it lights up with MRI and gadolinium. So it lights up as showing an area of concern that it may be prostate cancer. On T2 weighted imaging, and this is called an MPI, multi-parametric MRI. So you're looking at the MRI, spectroscopic, DC, dynamic contrast enhancement MRI, and diffusion weighted imaging. So lots of different approaches, and they put it all together to give it a PIRAD score, which stands for prostate imaging radiation addressing diagnostics. And they give it a score out of 5, not out of 10 like the Gleason score. It's a radiologic score. So it's a 2 or a 1 meaning unlikely. Very unlikely is a 1. 2 is unlikely that it's prostate cancer, clinically significant prostate cancer. This is only designed to see Gleason score 7 or higher, not Gleason 6s, unless it's significant Gleason 6. 3 is what they call intermediate, maybe yes, maybe no. 4 is likely, and 5 is very likely. So a PIRAD score 5 is very likely that it's prostate cancer. So again, we do the MRI, combine that, and if they find a different target or a spot that was not biopsied on the previous ultrasound biopsies, then I would then do or suggest that the patient have an MRI guided biopsy, and if the biopsy shows positive, depending where it is, then I know the areas that I have to treat. Those that were shown positive. And we get what's called concordance or discordance. The MRI, sometimes it shows only those areas that have already been proven by the biopsy, or if they haven't had a previous biopsy, only those areas that we biopsy are positive, and the areas that were not positive on the MRI usually don't biopsy, because usually they're in younger men. And then we can treat only those areas that are positive. So that gives us the confidence. So who's the candidate for now focal treatment? Partial gland ablation. The idea is Gleason grade 2, which is a 3+4, not 4+3, 3+4 or less, where it's only on one side, only 1 or 2 lesions, where the systematic biopsies have been negative, and that you haven't shown anything on the targeted biopsy either, and that low Gleason grade 1, low Gleason grade 6. So that's the best candidate. But who will we treat? Even if there's, a 4+3 or higher lesion, we'll treat. If it's solitary, or 2 2s on one either side, or on the same side, or solitary lesion crossing the midline. So there's different things. And again, depending on the individual and how motivated he is, even though it's higher risk cancers, if it's focal, proven by MRI, and if they're aware of the risk of recurrence, which is very similar to what it would be to radiation, and they're willing to roll the dice for focal treatment with the chances that it can be effective and it has much less morbidity than surgery or full total gland radiation, we will consider those patients as well. The problem is there's really no systemic approach or accepted approach to focal therapy as to how you diagnose them and which type of energy is being delivered. Presently, hemigland, full gland, total ablation, half the gland, regardless of how many cores are positive, et cetera, et cetera. And looking at what's presently available today, both in clinical trials as well as in accepted or available public treatments, if you will. So HIFU, cryotherapy, photodynamic therapy, intensely related electro treatment that someone had asked about earlier on, focused laser ablation, focal brachytherapy, microwave ablation, radio frequency ablation, partial androgen, partial prostatectomy, and TULSA, which is a transurethral ultrasound system, prostate ablation, but it's transurethral rather than transrectal, which is the HIFU. And these are the kind of responses you're seeing: biochemical disease-free rate with the range, as well as the focal retreatment range, if those that had focal retreatment, the salvage treatment. So this is what we're looking at. And it's all over the map. And some of them, as you can see, the numbers of studies and reporting are very, very small, or the number of try to compare data. So the longest and the most, I guess, robust data is within the HIFU aspect of it. And so in HIFU, 39 HIFU studies reported, no randomized controlled trials. Again, a lot of them were retrospective. Follow-up is very variable. 23 of the trials had MRI follow-up to determine if those recurrence based on MRI. Overall risk of recurrence in all comers, 6 to 30%, depending on the study. Most studies, and a few showed higher retreatment rates with ablation, 4 to 30%, need for radical prostatectomy, again, 2 to 25%. So again, it's a real mixture, but showing that very few required retreatment and a lot you could retreat, and looking at the biochemical recurrence rate based on the Phoenix classification, as we said, not just any rise from nadir, but looking at the nadir plus 1.5, 8 to 27%. The worst doers or the worst responders, obviously those with the anterior cancers where you maybe didn't reach it completely because they had a big, tall prostate, bilateral disease, or those that did not reach a PSA nadir that was quite low. Remember, because we're only treating focal, we don't expect the PSA to go to 0, but the whole concept of PSA for prostate cancer is that prostate cancer, the concentration of PSA in a gram of prostate cancer is 10 to 30 times greater than in a gram of benign tissue. So a man has a big PSA for either a big benign prostate or from a little bit of cancer within that prostate. So if we treat the cancer, the PSA should drop significantly, but it will not go to 0 because there's still a lot of tissue left behind. So then we can move on to how we're treating focally. Same SonaBlade machine. The United States, they have one that actually has MRI integration. And why MRI? So what do you treat? Do we treat the area of the Gleason 3+3 or a Gleason 3+4, or just a big 3+3, that type of thing? Or if it's an anterior lesion, do we treat that as well? So that's the next consideration. So how do we determine this? MRI, looking at the different things, versus a fancy three-dimensional truss or a grayscale truss, biopsy, but certainly the focal MRI with MRI fusion using ultrasound plus the MRI image and going those targets. That's the most effective and the most reliable. So using our MRI fusion, whether it be cognitive, meaning what we know we've biopsied, and using the MRI, looking at it and matching that to our treatment zones on the ultrasound image that we're doing in real time as we're doing the treatment, treat with HIFU, look for a tissue change. And again, as you can see here, orange or yellow means we've achieved at least 65 degrees Celsius to 100 degrees Celsius, and orange is better than yellow. And if it's green, it means we haven't achieved that temperature, and we can go back and retreat that one spot or 5 spots, wherever we want to see. And again, this is the anterior zone, middle zone, posterior zone, that overlying the rectum. And this is showing us a 3-dimensional view. So we complete our treatment, we go back and repeat, treat on those spots. And then we hope the patient is finished and we let the patient go. This is again looking at the machine, showing a 3-dimensional view here of the prostate itself, and a slightly different screen than one I showed you before, where we've got the MRI image and focusing in that, and now focusing on treating in that specific spot. So what have we found in doing the focal treatment? Again, looking at overall and scores for quality as well as PSA. This is the trifecta. Again, trifecta, the blue line, disease pad-free, meaning totally continent, leak-free with pads, okay, pad-free incontinence. Pad-free continence, a little bit of leaking, but not leaking through the pad, so less than 2 pads per day. An erection sufficient for penetration. Those are the overall. And then the trifecta is putting it all together. So with the blue line is no evidence of disease, and all of these things compared. That's the purple line, which is right up here. So purple, we looked at 84% overall, that no evidence of disease, and pad-free, including or pad using 1 pad or 2 per day, no evidence of disease, and good erections, versus no pads at all. So only 39 of those, no pads at all, 95% versus the trifecta. So overall, tremendous response. Again, a little bit of cancer on the biopsy, 9 out of 39, but clinically significant cancer, meaning greater than 3+3, only 3 out of the 39 patients with the follow-up biopsy. So, and that's just treating focal in that area. So again, now looking at overall for HIFU treatment, focal, 83% biochemical disease rate at 5 years, erectile dysfunction, 11% versus, and incontinence, 0%. Costs is what we're showing today, 20, and that's Canadian. In the States, is 25,000 Canadian. Full GAN treatment, again, showing the exact same thing in the right patient, obviously, but a higher erectile dysfunction rate, as we talked about, and those that required had some degree of incontinence, now 0.6%, still very low compared to obviously radical prostatectomy, but higher compared to focal treatment. And that's why focal is better in both categories compared to total treatment. Now, focal, which is obviously much longer, and again, prostate less than 40 grams, $28,000. And then now looking at radical prostatectomy, 80%, so almost the same. Erectile dysfunction rate, though, is much higher, 87%, and incontinence rate could be up to almost 20%. And those of you that have had it, you know. And this is now Canadian dollars, what it actually costs to treat these patients. In Canadian dollars, $100,000. US dollars, it's probably over 200,000. And using radiation treatment, same thing. Significant potential cost on the system. Obviously, the patients don't pay for it, but this is what it's costing our system, looking at the rates. Okay, overall, what we saw is that regardless of the treatment, we don't cure everyone with prostate cancer, and the morbidity is significant, and the quality of life can be very significantly impacted as well. So HIFU, a non-invasive outpatient, patients go home the same day, their legs come back 2 to 3 hours after the treatment with the treatment with HIFU, as well as the spinal anesthetic. That's the only thing limiting their exit from the unit itself. They go out with a catheter, either suprapubic or Foley catheter, to determine when it comes out. From that standpoint, and the short-term and long-term cure rates are very, very good. Side effects, morbidity, erectile dysfunction rates, and incontinence rates are very excellent compared to the other treatments. So whether it be primary total, post-HIFU treatment, or radiation failure, HIFU is appropriate and very, very effective now for the HIFU lumpectomy therapy. So thank you very much. Thanks, Prostate Cancer Canada. I probably spoke longer than what you hoped I was going to speak, but I hope I've given you lots of information. Happy to entertain questions. And again, anyone who's interested, we have a website you can look at, and a few phone numbers, and Mary Duggan is our patient coordinator, if you will, and she coordinates all the inflow of data and information from you, and then passes it off to myself and one of my colleagues to give us that response, and we can then bring you into the system and answer any questions if you have them. Thank you very much again.
Thank you so much, Dr. Barkin. That was a very informative.